this sort of concept of when we're thinking about phenotyping and shifting away from specific diagnoses to this concept of airways disease, inflammatory airways disease, and sort of siloing different phenotypic elements, I guess. So clinical, biomarkers, treatment responses, and what we think about how the field is evolving in that domain. It's a very broad question, I'm sorry.
Yeah, I did. Well, I guess having given the talk, you can tell that I think it's not clear, it's unclear. So I guess what I do in the clinic and what I read about in the literature, there's a bit of cognitive dissonance sometimes, because I think I'm quite clear about, those patients who've had, for example, asthma since they were a child or what have you, and I'd be treating those with inhaled corticosteroids and other drugs, but sort of making sure that I treat them. I'm not yet convinced by the eosinophil story, so I'm not routinely looking at eosinophil. Oh, well, we sometimes do when they come in, just for interest, but I'm not quite sure what to make of that. So Martin McDonald's just done a PhD on that whole area, looking at eosinophils in COPD and exacerbations, and of course the impact of steroids on the eosinophils. So I think it's very murky, I think, and these studies, my view is, and Chris mentioned this and I mentioned in my talk, but so it's a very personal view, but my view is that I wait for the prospective studies. The other data is interesting, but I don't know that we should necessarily be making decisions based upon it. However, I think there is interesting data in terms of managing COPD that we've overused corticosteroids. There's a lot of data suggesting that in general practice and in specialist practice, steroids are overused widely, and I think that we could be looking at our practice and probably using lower doses. The doses that are used, for which there's regulatory studies done in the US were lower doses than have been done in the UK and Europe. So we've all tended to use high doses, for example, of fluticasone, and they don't use high doses in the States, and so I think Chris's point is well taken about that. I've gone off the topic completely because I can't answer the question. Chris?
I think when you're looking at phenotypes and how that applies to clinical practice, there are two ways of doing it. One is in a more general sense, and for example, sputum eosinophils is topical in Australia because of the work from Newcastle, but if you can't get access to sputum eosinophils as a test, then I couldn't care less how long people waft on about phenotypes with sputum eosinophils, because as a clinician, it's got no relevance to me because I can't access it. So I think it's important that people discuss phenotypes and talk about them and study them, but from a clinician's point of view, unless you've got access to that type of test, then it doesn't matter, it becomes irrelevant. When you do have access to the test, like blood eosinophils, then I think what you need to do is apply it to that individual patient. And you need to be aware of the data and understand the data, understand the impact that it has on groups of patients, but that doesn't necessarily translate to the individual patient in front of you. We know that LAMA-LABA inhalers work in improving breathlessness and quality of life and so on in COPD. So if you ask a patient with bad COPD, how far can you walk, 100 metres, I don't automatically fill them up with inhalers, because if the reason they can't walk 100 metres is because they've got dodgy knees and it's their arthritis that's stopping them. So that's a phenotype, it's a comorbidity that Paul pointed out. So I think in clinical practice, you've got to take all that information that you have from clinical studies and research and the guidelines and so on, and then apply it to that particular patient and saying, is this going to be of benefit in this patient? And particularly in COPD, because we're not trying to cure the disease. We're not trying to control the disease process, even except with smoking cessation. We're trying to make the patients feel better. So not reflexly just prescribing a whole lot of stuff is important in COPD.
Yeah, this question sort of follows on from your comment there, Chris, and I think triggered by both Christine and Paul's presentations, In almost every Western country, the median age for diagnosis of COPD is about 73, between 73 and 76, which is very, very advanced. And from the basic science point of view, it seems like the opportunity is about 3 decades earlier to do something that would be useful. So we have late-stage palliation and a classification system that picks up disease way too late. How can we open up the possibility of defining processes much earlier so that we could make preventative or true disease modifying medicines? It seems to me a very, very fixed way of thinking at the moment in the field.
Well, I'll preface my answer by saying I have a conflict of interest because years ago I was involved with the CLEAR program, which actually came out of Adelaide here, which was specifically designed to look for COPD much earlier in the course of the disease in clinical practice. And it did have some success in doing that. It's a little bit controversial, and I can't remember the name of the organisation, but some fancy Grand Poobah US organisation on screening is against screening for COPD because they feel as if early diagnosis is not going to alter the course of the disease. Other than smoking cessation, but you can tell people not to smoke anyway, whether or not they've got COPD. But I think that there are benefits in knowing what's going on with patients, and I think that anyone who is a smoker or has a smoker should have spirometry. I don't consider the age of the patient. So it used to be that people in Australia who took up smoking were doing it late primary, early secondary school, so you can have a fair bit of smoking behind you by the time you get into even your 30s. So you can have developed COPD. So, and spirometry is such a simple, easy test to do, and cheap and harmless. I don't see a reason why people know their height, their weight, their spirometry. Maybe that's being a bit excessive, but that's my sort of feeling, and I would agree with you that the more we understand about the disease in the community, the better off we're going to be in the long term of trying to identify earlier treatments that can prevent the disease from progressing into this more debilitating condition.
You're getting into the area of, and I know that Kerry Hancock has done a lot of this work in this area, looking at GPs doing spirometry, and GPs are not doing spirometry, and it's very hard. It's simple and easy, but it's not that easy actually to get a good sample of spirometry. And she's done this over-reading study, looking at GPs doing spirometry and then having someone review it, and it's not so easy. So, and it's not very well remunerated. So, unless you've got a practice nurse who's trained up, so there are sort of barriers, a bit like pulmonary rehab, really, sort of barriers that are always talked about and are difficult to resolve, even with the review of the MBS review of item numbers. But I totally agree with Chris. I also think actually that we also should be doing more. You're talking about the unifying airways, the COPD, asthma, Dutch hypothesis type thing. I think we're not doing enough spirometry, not only in ED for asthma, but elsewhere for asthma. And I'm seeing people with chronic asthma who think that, particularly having seen a lot of these thunderstorm asthma people coming through, so many of them are people who've had asthma before and just presented that one time, but we've been following them up now and doing their lung function tests, and quite a lot of them have got a degree of fixed airflow obstruction. They think their asthma is under great control. They never need to use a preventer. And what's a preventer anyway? It's Ventolin, isn't it? So I think there's a lot of work to do.
Can I just say on that topic as well, it's useful also to look at the different factors involved. Many of the approaches, some of these have been focusing on the patient and what they need to do, some have been focusing on what the doctors need to do or the practice, and some have focused on the system. And it's, I think, useful because there are problems in all of those areas to consider all of the factors. So, for example, patients, we know that they avoid seeking help because of the stigma of being diagnosed with COPD, a smoking illness. So there have been 3 to 5 studies looking at that and the delay. We know that there are doctor factors involved as well, and we know that there are systemic factors. So I was speaking about pulmonary rehab, but if you ask a number of people in primary care, well, how do you refer to pulmonary rehab and when is it most appropriate? There are still issues there.
Thanks. We've got another question.
Yeah, I've got a question. Occasionally, I see patients with history of exertional breathlessness without any history of exacerbations. They're probably in their 60s and their 70s, no history of smoking, and they've got, airflow obstruction. So what's your approach to these patients? Do you treat them initially as COPD, therefore you don't actually have ICS there, or do you treat them with ICS-LABA and see what happens a few months down the track, whether there's actually any improvement in their spirometry? And my second question is about pulmonary rehabilitations, because you mentioned about the treatment effect that lasts usually 12 to 18 months. How realistic is it to offer pulmonary rehabilitation after that, and whether there's any study to look at what you do after the inpatient pulmonary rehabilitation? Do you do community or like in-home sort of pulmonary rehabilitation maintenance program to make sure that the treatment effect lasts longer than 12 to 18 months?
We'll take that first.
All right, we'll handle that one first. With pulmonary rehab, you're spot on. It's often not practical. So hence there is an approach where we want maintenance to occur. So maintenance has been a big topic of research over the last 10 to 15 years. To this point, though, the best model of maintenance still is not clear. So there have been various things tried, from telephone coaching to nurse visits to pulmonary rehab in the home. There's been 6 month, 12 month, 2 year, 5 year follow-ups. But we do know that some form of maintenance is better than no maintenance. The exact model we don't actually know, but we do know a certain minimum amount of exercise. But there are essentially what we need to look at is what the barriers are for them. Sometimes that's distance, so that might be some televersion. The pulmonary rehab is offered online in some areas. So in trying to increase access, for example, in Australia, there is the Lungs in Action program, which is like a step-down program from full-on pulmonary rehab, which is usually run by exercise physiologists or physiotherapists running exercise classes and so on. So ideally, the pulmonary rehab program should have links with all of these different services so that it becomes a continuum of care.
Yeah, that's really important. And what I emphasise to patients in pulmonary rehab classes, in clinics, and indirectly through GPs and practice nurses and so on, is that the pulmonary rehabilitation is not really the treatment. The treatment is long-term regular exercise, and the pulmonary rehab is teaching you how to do that exercise. So it's not an 8-week course that then stops and you're finished and that's the end of it, you can forget about it. That's the start of your lifelong exercise program, and you are going to be doing half an hour of exercise every day for the rest of your life. And the trick is, of course, to try and get people to do that. And the advantage of pulmonary rehab is it's a fantastic way of teaching people how they can exercise confidently. But most of our patients are humans, and with the normal human frailties and weaknesses, they need support over a period of time to maintain that exercise. And whether that support comes through sort of huffers and puffers groups that the Lung Foundation have, whether it's through going along to a park run, whether it's with an exercise group down at the local gym, local community health centres that run these sort of things, or whatever. But whatever suits their lifestyle, whatever suits their mode of exercise, it's not just do a pulmonary rehab program and then hope for the best. Ongoing exercise is critical.
Can I just answer the point about the patient with the mild airflow? I think mild airflow obstruction, you said? Moderate, okay, whatever. Non-smoker, yeah? So, I guess it's the careful history. I go back to the careful history, the childhood asthma, the family history, those kinds of things. You may find that they were atopic and they may have had undiagnosed asthma, so it just could be that. So TLCO we haven't mentioned, but, that can be useful as well. Maybe they've got some other condition, maybe they're obese, maybe they've got coexistent diastolic dysfunction, etc. So I guess, a lot of people come in, don't they, and they've just been given a label of COPD. In my hospital, we actually did a study, which I must publish. But looking at patients with the label of COPD, many of them didn't have COPD, or they had some mild airflow obstruction. We use lower limit normal, so it might have been trivial airflow obstruction. But it made no difference. They still sort of went home. We gave this information to the registrars and the other consultants, and they still went home on treatment for their COPD. But I guess I'd be looking for other reasons, and then considering starting symptomatic treatment if you've ruled everything else out. Yeah.
So I think, and I'd agree with everything with Christine just said, and you've done all of those sort of things, and you're left with a patient who's symptomatic with airflow obstruction. You don't know whether it's COPD from passive smoking or some other toxins, or whether they've had asthma in the past and they've now got airway remodelling, and whether or not that asthma will respond to inhaled corticosteroids. So I don't think in clinical practice we have a good way of deciding whether they're going to be corticosteroid responsive or not. So therefore, I give them a trial of inhaled corticosteroids. And it's very clear in my mind and in the patient's mind and in the notes that this is a trial for a set period. There's no evidence around this, so you pick what time frame suits you, but I would say months, and then repeat the spirometry and see how they've responded. If they've gone back to normal, then you've got a clear-cut diagnosis of asthma and just treat them as asthma. If they haven't changed whatsoever, then what label you want to give them probably doesn't matter, whether you want to call them COPD or asthma with fixed airflow obstruction or whatever, but they're not responding to inhaled corticosteroids, so I wouldn't keep the inhaled steroids going because they've got downsides to them, as I pointed out. And if they move somewhere in between, they've probably got a bit of both, so you try and maintain them on the lowest possible inhaled corticosteroids dose that maintain the level of function that is the best that you can get out of them.
We might allow one or two very quick questions, if that's okay. Or
hi, I've just got a question about the Cochrane evidence looking at ICS and exacerbations versus ICS and pneumonias, because it seems to be almost opposite. And I'm wondering what your thoughts are on that. So, I mean, from what you presented with ICS and exacerbations is a quarter less, but obviously that, with the use of ICS, there are many more pneumonias, and although not every exacerbation is infective related and not every pneumonia might lead to exacerbation, does that seem opposite to what you think?
Yes and no. Remember, it's not black and white. So exacerbations is basically the patient's symptoms getting worse. So you're correct in that they may not be infective. So it may be some unpredictable thing that we don't know, they've got more bronchospasm or whatever. It may be that they've become anemic, they've got a heart failure, they've got a pulmonary embolus, an arrhythmia or whatever. Then you have another group of exacerbations which are clearly infective. So sputum has become discoloured, maybe they've got fever, those type of things. So they're obviously infective exacerbations. But only a small proportion of those infective exacerbations will actually be pneumonia. So a person with COPD can have an infection in the lower respiratory tract which is not pneumonia. So inhaled corticosteroids can reduce those type of infective exacerbations, but overall, because the percentage of them with pneumonia is small, even though there's an increase in pneumonia, the overall number of exacerbations is in fact less. So for example, the TORCH study where the pneumonia was studied quite extensively, in the arms where they had inhaled corticosteroids, 6% had pneumonia, whereas in the arms without inhaled corticosteroids, 3% had pneumonia. So that's the size of the effect that you're seeing with inhaled steroids. So you factor it in, it's not a black and white, I'm not going to use inhaled steroids because I'll get pneumonia. No, you're slightly increasing the risk of the patient getting pneumonia. If there are factors that suggest they're more likely to get pneumonia, like they've had it a few times before, then that would push you well away from inhaled steroids. If you are going to use inhaled steroids, probably the most important thing with the pneumonia risk is to tell the patients, if you look like you're getting an infection, that is your sputum's changing colour, get antibiotics quickly. On average, patients with COPD take about 10 days to report an exacerbation after the exacerbation starts. So they tend to sit around on the exacerbation. And careful analysis of these pneumonia episodes in the clinical trials show that the increase in pneumonia is people who have had an exacerbation that then goes on to pneumonia, rather than pneumonia just coming out of the blue.
Sorry, just one last quick question from Dr. Sergiotis.
Just a quick comment as to what I have been seeing in clinical practice for many years, and that is often getting a handle on how often we're actually underdiagnosing asthma in COPD patients. It's never ceased to amaze me. I monitor people's spirometry very carefully, whether they have either ends of the spectrum or they're in the middle or have mixed pathology. But it's extraordinary how often people will feel at their best and have their best FEV1 immediately after completing their course of oral steroids following their first exacerbation. And how difficult it is often to ever be able to achieve that again subsequently. Does anyone have any comments?
Yes, so it's a complex question. I would not rely just on how patients feel. If we handed out prednisolone to everyone here now, and you all just took 25 milligrams of prednisolone or something, you would get a bit of a euphoric effect. So prednisolone on its own could just make people feel a bit better. In the situation of an exacerbation, you've been crook for some time, now you're feeling better. Irrespective of why the exacerbation got better, you're feeling better. So it doesn't necessarily mean that there's a long-term corticosteroid responsive airway inflammation in the patient. I think if you're going to say that someone's got COPD and asthma, then you want to clearly demonstrate that there's been an improvement in their airflow obstruction in response to, and we would use inhaled corticosteroids. In the old days, and I'm old enough, going back into the 90s, we used to give courses of prednisolone over a few weeks to patients in COPD to see if they responded. But subsequent studies have shown that that's pretty meaningless, so we don't do that anymore, plus there's potential harm. So if they're responding to inhaled corticosteroids on spirometry over a period of time, then you might say, yes, it's an asthma component with their COPD, but I certainly wouldn't rely on just how the patients are feeling.
And you don't just mean 200 mils and 12%, do you? You mean a significant response?
Yes.
I suspect most of these patients do actually have asthma and COPD, and what we're seeing is a compliance effect. They're taking their tablets once a day, and they're getting as well as possible. And I see this confirmed spirometrically over and again, and they can never get quite as well as they could on their inhaled corticosteroids because I don't think they're taking their medications properly. I think that's an under-recognised phenomenon in COPD patients.
Yeah, that's a critical point, that with inhalers, they need to be taking them, but also taking them properly. But, I mean, you would never leave someone on long-term prednisolone just because of the adverse effects are so high.
We really need to wind this session up there, so can I ask you to join me once again in thanking the three speakers for an excellent session.